Okay, more about the newborn assessment. You'll want to be familiar with the neonatal vital signs, which is this table, especially noting the respiratory rate and the heart rate. These will be important factors in assessing infants. This table is helpful because it gives you an idea of some of the things that can be wrong depending on the symptom that you're seeing. So you probably want to check this table out too and get familiar with it. All right, so remember, apnea is the cessation of breathing for greater than 20 seconds, or any apnea associated with cyanosis or bradycardia. Sometimes we refer to this as A's and B's, apneas and bradycardias, or ABDs, apnea, bradycardia, and desaturation. If the infant is premature, we call it apnea of prematurity. This happens quite frequently and can range anywhere from self-resolved to requiring PPP. Premature infants usually get caffeine citrate to help manage their apnea of prematurity, and we also sometimes have to put them on respiratory support like high-flow nasal cannula or CPAP to continuously stimulate them to breathe. Apnea of infancy is basically the same thing as apnea of prematurity, except it happens in term kids and older. Periodic breathing, though, is normal for infants, and it really just means they don't have a regular rhythm or depth of breathing. Many times when we see periodic breathing, the baby will desaturate or have a heart rate dip, and we can see on the monitor that they were shallow breathing or slowly breathing. This is usually self-resolves and does not require any respiratory intervention. An apparent life-threatening event is a witnessed unexplained episode of cyanosis, apnea, or change in muscle tone. It could be possibly choking or gagging that can occur in infants. Sudden infant death syndrome, on the other hand, is the sudden, unexplained death of a child less than 1 year of age. Some of the major signs of respiratory distress in babies include cyanosis, or a bluish color of the skin. These babies can also present with pale or dusky skin color. Retractions, which are the sucking in part of the chest wall in specific places. Nasal flaring, which is an attempt to make the airway larger to get more air in with each breath. And lastly, grunting, which is just like it sounds. Infants and children will grunt to create their own auto peep in an effort to improve their oxygen status. All of these signs are respiratory distress in infants, and intervention should be considered whenever you see any one of them. All right, here we go with cyanosis. As you can see in the top picture, that baby's pretty blue. And this happens usually right after birth and usually resolves, but sometimes it doesn't, so we have to intervene. The lower picture on the left is called circumoral cyanosis, which is just the area around the lips that turns blue. While this may seem like it's better than that kid on the top, it's a pretty big deal because circumoral cyanosis is a sign of central cyanosis, and this baby needs some intervention right away. Lastly, the picture on the right is a dusky or pale baby. This one's a little more difficult to notice because some babies are just pale. You just need to be aware of dusky or extra pale infants as a sign of cyanosis, and you might need to intervene or just closely monitor. One more type of cyanosis that we talk about is called acrocyanosis, and it's basically just that bluish tint in the hands and feet, those deep extremities. This is very normal for infants and can take quite a while to resolve, sometimes even up to 24 hours. This type of cyanosis is completely normal and no intervention is needed. Newborns have a high chest wall compliance due to the amount of cartilage. This later develops into bone when they become adults, which is why you haven't heard of anything called retractions up until now. Places that you will see retractions include between the ribs, which is called intercostal retractions, below the rib cage, which is subcostal, below the sternum, which is substernal, and or above the sternum, it's called suprasternal. You can see in this video, this baby is showing some subcostal and substernal retractions. Here's another video that shows you the retractions and their apparent locations. The intercostal retractions aren't as well seen, but you'll kind of get an idea of what they look like. All right, in this video, you can see nasal flaring. Okay, now that we've got the respiratory distress symptoms down, we move on to blood gases. These are two of the types of blood gas results you might see in infant. The first one is acute alveolar hyperventilation, which is also known as acute respiratory alkalosis. The second one is acute ventilatory failure or acute respiratory acidosis. Take some time to think about the kind of blood gas values you might see that fit this description. Okay, one of the assessment tools we have is our pulse oximeter. You guys should be pretty familiar with this. It's safe and reliable, non-invasive tool that gives us a good idea of what the arterial saturation is. Normal SpO2 values in term babies are 97%, but in premature infants, we actually titrate the oxygen to keep it lower depending on their gestational age, sometimes even less than 90%. There are other times in the NICU or nursery that we use pulse oximetry a little differently. We place a probe on the right hand, which we call preductal, and another probe on one of the feet, which is postductal. We use this to measure a difference between the two, and if it's greater than 10%, it tells us we have a right to left shunt. Right to left shunts in babies are usually indicative of congenital heart disease, which we will talk about later in the semester. Capillary blood gases are the main method of assessing blood gas in infants. This method does not give us reliable oxygen status, but since we have our trusty old oxygen saturation monitor, we can go ahead and use this to assess the rest of our ventilation. The pH, PCO2, and HCO3 are all reliable results from the capillaries, and this is usually the way that we sample in the NICU from the heel, which is nice because it does not require a lot of blood. The book does outline a procedure, but it's important to understand that some of the issues that can occur when collecting capillary blood gases. Inadequate warming of the site, clots in the sample tubing, excessive squeezing or milking, which can contaminate the sample with interstitial fluid or venous blood, and the exposure of the blood to air during sampling. Arterial blood gases, you guys should be pretty familiar with this. It's very similar to the way we do it in adults. You get your pH, your PCO2, your PO2, and your bicarb values. The reason you want to do an arterial gas is when you're trying to evaluate the acid-base balance along with the oxygenation status of the baby. This is not done very often in the NICU, but it does happen from time to time. The umbilical artery line is where we usually end up drawing an arterial blood gas from, and this is a special line that's placed by the physician through the umbilical cord, and it can be used to sample arterial blood gases, but it can also directly monitor arterial blood pressure. The transcutaneous monitor provides a non-invasive estimate of arterial oxygen and carbon dioxide. This is a super safe method of assessment, and it decreases the amount of invasive blood gas samples that we need to gather. It also can provide continuous monitoring for our patients, which is helpful. But some of the downsides is you can have tissue injuries like burns or blisters or skin tears at the measuring site. This usually only happens in premature infants who have poor skin integrity. And our last slide talks about our Silverman scoring system, which is used to evaluate an infant's level of respiratory distress. And our Ballard score, which is something that nurses and RTs can use to determine the gestational age or estimate the gestational age of a baby after they're born.